I believe the pertinent questions with respect to my topic is A, is ADT actually promoting cardiovascular disease? If so, why ADT may promote cardiovascular disease, and what can we do about it? It's very important to mention that the prostate cancer patients, being prostate cancer patients, are actually at high risk of cardiovascular disease. The American Heart Association considers a 20% 10-year risk of coronary artery disease to be high. Patients with prostate cancer are therefore at high risk for cardiovascular disease because the risk of MI, stroke, or cardiovascular death is calculated as more than 2% per year, and this has been recorded by numerous studies, which I will show. The risk of MI, stroke, or cardiovascular disease in prostate cancer men on ADT is even more doubled as per observational trial, and it's more than 4% per year. So therefore, cardiovascular disease is very prominent in prostate cancer patients. As you can see, this is an observational population-based study that showing by Keating et al. For patients with local regional prostate cancer, and this is more than 37,000 patients. You can see that the risk of cardiovascular disease or cardiovascular event is more than 2% in patients with no ADT, and when you go on hormonal manipulations, LH agonist, orchiectomy, combined androgen blockade, and even oral antiandrogens, this exceeded and increased. This increased risk has been recorded numerous times, and this is just an example for a meta-analysis of 6 population-based observational studies that included over 119 ADT recipients and over 150,000 ADT non-recipients, and this demonstrated a hazard ratio for cardiovascular mortality of 1.17 among the ADT recipients. So this is for cardiovascular mortality. But we have to bear in mind that the existing observational evidence linking ADT use with cardiovascular disease compromise largely data from administrative databases, which are limited in the covariates recorded related to cardiovascular risk factors. And indeed, the findings from these observational studies contrast with an earlier meta-analysis of randomized trials of ADT, which demonstrated no access cardiovascular deaths in the ADT arm in over 4,000 participants who experienced more than 500 cardiovascular deaths. In fact, in this meta-analysis, ADT exhibited a relative risk of cardiovascular death of 0.93 as compared with control. While this evidence from this study suggests that excess cardiovascular mortality among ADT recipients is unlikely, the randomized trial have limitations with respect to this outcome. Among the 8 randomized trials of ADT, 4 featured control arms that received ADT in a deferred manner, which may have diluted any adverse cardiovascular effects of ADT. Cardiovascular outcomes were not well characterized in the randomized ADT trials, and ascertainments of adverse cardiovascular events may not have been systemic. Therefore, this could reduce the power of these trials to detect the effect of ADT on cardiovascular event incidents. Now, owing to the tendency to recruit men who are otherwise healthy into randomized clinical trials, men with greater comorbidity, including cardiovascular disease, may have been excluded from these trials. And indeed, the largest burden of cardiovascular deaths we know in men with prostate cancer is seen in those with greater comorbidity. So for these reasons, there remains uncertainty, I believe, about the role, if any, that is attributable to the ADT in promoting cardiovascular disease. So, is ADT promoting cardiovascular disease? We are investigating that in the Radical PC trial, which is actually 2 prospective trials, one nested within the other one. The first one is the role of androgen deprivation therapy in cardiovascular disease, a longitudinal prostate cancer study, the Radical PC1, which is a prospective cohort study of men with newly diagnosed prostate cancer and men commencing on ADT. And we have now more than 720 patients. This is an analysis of about 600 of them, the first 600 or so. And you can see, as expected, men that are commencing on ADT have more prevalence of metastatic disease. But what's interesting and very important is that these men, the men who are commencing on ADT for either an indication as for metastatic disease or men with high-risk prostate cancer that will receive, that are about to start radiation and ADT, you can see that these men statistically have higher prevalence of cardiovascular risk factors and established cardiovascular disease. So here, for example, for coronary disease, there is a double risk, if you will, or a double prevalence of 25% in those commencing on ADT compared to those who are not. And all of these risk factors are marked here in red. In green, you can see that they also statistically significant more chance for the men who are commencing on ADT to be already on cardiovascular prevention strategies and medications such as statins and antiplatelets. So is ADT promoting cardiovascular disease? I believe this question may not be answered because in men who have the indication, on those men we are about to start ADT, we have more baseline cardiovascular disease characteristics to start with, and they're probably more prevalent to be on cardiovascular prevention strategies. So therefore, I believe it's more so comparing oranges to apples. So the model, if you will, is that a prostate cancer patient with high-risk disease, those specific patients who are about to start ADT for either a metastatic disease or for high-risk prostate cancer or intermediate-risk prostate cancer with ADT and radiation therapy, those men have high prevalence of cardiovascular risk factors such as a higher age, obesity, hypercholesterolemia, pre-existing cardiovascular disease or coronary artery disease, and hypertension. And essentially, it may be that the application of ADT is just the stroke that breaks the camel hump and brings the cardiovascular event. So how do we manage that? One can suggest that we'll use a more cardio-friendly ADT modalities, and I will elaborate on that, or we may use some primary prevention to reduce the risk of developing cardiovascular event with ADT. How might ADT accelerate cardiovascular disease? Well, this is a two-way model. Obviously, we know that cardiovascular risk factors such as the metabolic syndrome, dyslipidemia, central obesity, dysglycemia can all be attenuated by ADT, and ADT can promote their development. And this would induce coronary artery disease. But the interesting thing is that once you have coronary artery disease, it may be possible that ADT would induce plaque vulnerability, i.e. cause stable atherosclerotic plaque to rupture and cause a cardiovascular event. And my group believes that this is at least can be partially explained by a disbalance between testosterone and FSH, namely a hormonal profile of castrated level of testosterone with elevated levels of FSH. And we have shown that in a mouse model of LDL receptor knockout mice, we could show that ADT does induce the metabolic syndrome. It clearly induces obesity that can be measured by a CT scan, as you can see here, or by changes in leptin levels and dysfunctional fat. It can also induce a glucose intolerance. But most importantly to our topic, it induces atherosclerotic plaques. And you can see here in the gray bars that all modes of ADT, i.e. orchiectomy, leuprolide or GnRH agonist, and the Garelix or GnRH antagonist do induce a significantly larger atherosclerotic plaques in these mice. However, one can see in the white bars that the amount of necrotic core, which signifies a vulnerable plaque to rupture, is significantly lower with the Garelix compared to the leuprolide and to orchiectomy, and in fact it's not different than that in control. And this is very important because the necrotic core is a marker, or if you will, a phenomenon of plaques that are vulnerable to rupture. And when the established plaques are ruptured, then a thrombus comes by, the entire lumen of the artery is occluded, and one gets MI, cerebrovascular incidents or stroke. And we have established both in the mouse model, and it has been shown also in the CS21 extension study, that the use of the Garrelix is associated with significantly inhibited levels of FSH. And this also applies to the functional biological function of FSH, and you can see that in the mice that we have studied, the lower levels of FSH were associated with reduced weight of the testicles or reduced volume of the testicle, which is a classic phenomenon of FSH activity. So FSH is significantly inhibited with the Garrelix, mildly inhibited with Leuprolide, and increased with ochiectomy. Now, the FSH receptor is expressed in the atherosclerotic plaque. We've shown it here to be expressed in the macrophages within the plaque, and those are very important component of the dynamics within the atherosclerotic plaque, because they are the main cause of or have a central role in plaque vulnerability. Those macrophages also accumulate fat and causes the atheroma, and we could show that indeed if you treat those macrophages with FSH, they tend to accumulate more fat and therefore tend to be more dangerous in terms of their ability to release tissue factor and cause the plaque rupture and thrombus. So, is there any evidence, clinical evidence, for a superiority of the Garrelix in terms of cardiovascular event occurrence in patients commencing on ADT? This is, we have some retrospective analysis of pooled analysis from clinical trials, prospective clinical trials of about 2,300 patients, randomized in 6 different trials, 2-to-1, to receive either the Garrelix or LHRH agonist. This has been done by Albertson et al. And those 2 groups had similar cardiovascular risk profile, but nevertheless, one could see that within a year, there was a 44% reduction in the risk of cardiovascular event or death with the Garrelix compared to Leuprolide. Now, this is a post hoc analysis of a retrospective analysis of prospective trials that were not meant to test cardiovascular outcome, but rather a clinical efficacy and oncological efficacy of the Garrelix. In this AUA, we do present here an abstract looking at a pilot prospective randomized trial between agonist and antagonist. This trial has been led by Professor David Margel from Rabin Medical Center, Tel Aviv University, and what it shows that 66 patients with pre-existing cardiovascular disease were randomized 1-to-1 to receive either GnRH antagonist or agonist. A cardiovascular event was considered to be one of the following: MI, ischemic or hemorrhagic CVA, arterial or embolic or thrombotic event, also some soft endpoints such as emergency room visit or hospitalization due to ischemic heart disease, and revascularization. The median follow-up is currently 8.5 months, and what you can clearly see is that agonists had 30% chance of patients on agonists had 30% chance of developing a cardiovascular event compared to 6% only in patients who were treated with antagonists. Most of these events were including emergency hospitalization for these events, as you can see here. And those were real events. We can see here that if we, the analysis that we did for the levels of NT-proBNP, this is a very good marker for cardiovascular, future cardiovascular events. And this, we could show that if we measured the NT-proBNP before these patients were randomized to receive their ADT modality, i.e. baseline, this could predict future events. And this has been shown by other studies, such as a study that showed that preoperative BNP or NT proBNP can predict very clearly hard endpoint cardiovascular outcome 30 days after surgery. So this is a very good marker. Now, the interesting thing is this analysis where we analyze the change in FSH levels at 3 months from baseline for each patient. And what's very interesting, and this you can see it here in this waterfall plot, is that 47% of the patients who had decrease of less than 60% in their serum FSH levels within 3 months, i.e. 3 months from baseline, had an event, 47%, compared to only 7% event rate in patients who had more than 60% inhibition in their FSH level within 3 months. And this was highly statistically significant. Now, within the agonist arm, patients with lower than 40% inhibition of FSH are twice much likely to experience a cardiovascular event, 28% versus 57%. So we do believe that FSH, there is a signal at least, that FSH level or the change in FSH level is associated with the development of cardiovascular event once patient is castrated. And of note, all patients in this study achieve castrated level of testosterone. So prostate cancer patients needing ADT have higher baseline cardiovascular disease characteristics and risk factors, and we know that from the analysis of the radical PC patient data up to now. The question, therefore, may not be as much as whether ADT promotes cardiovascular disease, but rather how can we prevent it in this patient population. And there are two options, either using GnRH antagonist or other FSH inhibitors, as we do have, I believe, signals to show that this may be associated with less development of cardiovascular events, or perhaps without usage of routine primary and secondary cardiovascular prevention. Now, the treatment strategies for cardiovascular disease primary prevention is associated with, is well established from multiple prospective randomized trials. And we do that with the usage of aspirin, cholesterol-lowering agents such as statins, and blood pressure control, even at values that are seen to be normal. And this is with ACE inhibitors or other blood-lowering medications. It also associated with lifestyle changes such as diet, exercise, and non-smoking. And a number of healthcare strategies have been shown to reduce adverse cardiovascular outcome in the general population in primary prevention setting. And this, as I mentioned, includes the use of aspirin, statin, and ACE inhibitors among those with at high risk of cardiovascular event. And I would argue that prostate cancer patients are having high risk of cardiovascular event, particularly those who are commencing on ADT. This is just one example for that. This is over 10,000 hypertensive patients with other cardiovascular risk factors, but with no dyslipidemia that were randomized to receive atorvastatin 10 milligrams or placebo. And this is an old trial, a prospective trial in Lancet that showed a clear benefit of 36% reduction of risk of cardiovascular event in this patient population, and this is already within a year. So could we reduce the risk of cardiovascular event in patients commencing on ADT? And we saw from the Albertson data that events are often happening within the first year. So for that, we are conducting the Radical PC2 trial, and this trial is aimed to determine whether systemic cardiovascular and lifestyle risk factor modification strategies reduce the risk of cardiovascular disease in men with a new diagnosis of prostate cancer or men who are commencing on ADT. This trial is nested within the Radical PC trial, and I will not go over the details for the sake of time. Just to mention that patients are eligible for the Radical PC2 if they do not see a cardiologist every year, and if they are not taking all of the following: aspirin, statin, ACE inhibitors, or exercise more than 4 times a week. The intervention in Radical PC, they are randomized in an open manner to either standard care or for intervention, including the usage of aspirin, statin, ACE inhibitors for blood pressure of over 130 over 80. They receive dietary counseling, exercise advice, and support to quit smoking. This is quite a busy schedule, but we do assess them for many parameters, including frailty and others, as well as obviously cardiovascular endpoints. And the outcome is a composite of primary efficacy outcome: cardiovascular death, myocardial infarction, stroke, heart failure, or arterial revascularization. And I believe that this trial, which is well going, we have more than 720 patients up to now, and more sites are joining. I believe this would allow us to understand whether systemic cardiovascular lifestyle risk factor modification strategies reduce the risk of cardiovascular disease in men with newly diagnosed prostate cancer, but more important, if that also help in reducing the cardiovascular event in men commencing on ADT. And the question is, does systemic cardiovascular and lifestyle risk factor modification strategy does add any benefit for patients who are on specific ADT modality? We do not know yet what is the relative risk reduction in patients on GnRH agonist compared to patients on GnRH antagonist, but more so, we don't know if that is also can be further reduced by cardiovascular prevention strategies. It may be that patients with commencing on ADT with LHRH agonist don't have more cardiovascular events if they are on cardiovascular prevention strategies, or it may be that even with that, the GnRHs have more protective effects. You have to stay tuned for results from radical PC2 to be coming, and I hope it will come sooner than we think, and it all depends on recruitment, which is commencing quite well right now. Lastly, I would like to thank the following people who are with me in helping me. This study could not have been done without them. Dr. Daryl Leong, a cardiologist from McMaster University, who is my co-PI on the Radical PC trial. Dr. Helga Duvan Worden, who is working with me in the lab and is responsible for the mice data that you saw, and Dr. David Margell, who is a colleague, a friend, who conducted the pilot prospective randomized trial of agonist versus antagonist. Finally, I'd like to also thank Prostate Cancer Canada and the Movember Foundation for funding our Radical PC trial. Thank you.